Welcome back, everyone, to this year's See Arthritis event at the Canadian Rheumatology Association and Arthritis Health Professions Association's annual meeting in Winnipeg. I'm Kelly Lendvoy, VP of Communications and Public Affairs at Arthritis Consumer Experts. And I'm really excited today because we get a chance to talk to one of the young leaders in our community, and that's Emilie Pianarosa. She's a second-year medical student at the University of Calgary, focusing on arthritis research, working with some of our research leaders in Canada at the U of C. And she's building on a solid foundation that she's gained in life sciences with a thesis in epidemiology from Queen's University and a Master of Public Health in Epidemiology from the University of Toronto. Emilie, welcome.
Thank you. I'm glad to be here.
So you're in Winnipeg, and you're going to be, you've got an abstract and a poster that you're presenting, and it's on reducing avoidable care use and improving care experience, a focus on emergency department use by people with inflammatory arthritis.
Exactly.
So to start us off, maybe you can describe to us what is going on with people with inflammatory arthritis and their use of emergency department services, and what are the reasons why there are the numbers of patients that are seeking that service.
Sure. So in our study, we in the population that answered the survey that we put out, about a third of the people had actually tried to access other avenues before going to the emergency department. So those avenues were their family doctors, walk-in clinics, virtual phone consultations, rheumatology appointments. And after seeking one or more of these outpatient resources, they then felt the need to proceed to the emergency department to get their healthcare needs met. Another third of the individuals actually thought that the emergency department would be the best place to manage their symptoms. So they didn't seek any other resources. They felt that this was the best place for them in that moment. So they went right to the emergency department. And the last third-ish of the population, they had actually returned to the emergency department within 72 hours of another emergency department visit because their needs weren't met at that original visit. Their symptoms weren't appropriately addressed, or their symptoms worsened, or they weren't able to appropriately access the outpatient resources that were suggested to them. So they actually went right back to the emergency department to further help their concerns. So those were the three avenues where people access the emergency department.
And when you surveyed these respondents, what was that experience like in the emergency department, and what particular challenges did they face?
Mm-hmm. Yeah, often patients left the emergency department feeling really frustrated because they felt that they were getting dismissed or not comprehensively assessed and then rushed out of the emergency department, which is pretty unfortunate. And then patients perceived that the onus was on them to navigate the healthcare system, which is not unique to inflammatory arthritis patients. This is a concern felt by a lot of patients with different healthcare conditions and chronic disease specifically, because our healthcare system is quite complex and not often straightforward, and it's difficult for patients to take that responsibility on themselves to access the appropriate resources for their concerns. And often, with respect to their chronic disease, they felt that their experience of chronic disease wasn't actually really acknowledged, and their symptoms were not really appropriately attributed to their arthritis condition or not. Because patients with chronic disease have been living with these symptoms for so long, they're experts in their own condition. They felt that they weren't really being heard and that expertise wasn't really being acknowledged as part of the management plan. So that was very frustrating for them as well.
So if we look at it through the lens of health equity and social determinants of health, did you also see a disparity in the experience and the challenges faced by people who, let's say, are BIPOC, Black, people of color, Indigenous, low income, low education, people who struggle possibly with language barriers, and even the difference between urban and rural? Were you able to tease out any of these findings?
Unfortunately, in this study, we didn't go as far as to tease out based on demographic factors. One of the limitations of our study actually is the fact that a lot of people didn't answer their demographic questionnaire, the demographic part of the questionnaire. We believe this might be in part because of the way the questionnaire was distributed. We're not entirely sure, but it wasn't, we weren't able to really tease out those differences, unfortunately, but that could be really important work to do in the future.
And then what about when these people left the emergency department in terms of continuity of care? Were they able to follow up with a rheumatologist? Were they able to receive the care that they needed following the visit?
So often what was happening is that at the end of the visit, the emergency physician would suggest, follow up with either primary care or rheumatologists within this time frame to get these symptoms addressed. And often what we were seeing is that patients were not able to see those providers within that appropriate time frame for their concerns. So up to 40% of patients were unable to reach their rheumatologist or primary care provider to address these concerns, which is really impacting, right, their care, and often leads to them representing to the emergency department because they're not able to access the outpatient ambulatory care services.
So this is sort of all part of a model of care for arthritis, and this is really shockingly failing the patients who obviously need the support. So I think our audience would be interested. What conclusions did you make? What sort of recommendations coming out of this work have you come up with?
So we sort of saw the recommendations as a 3-pillar approach. So before presenting to the emergency department, how can we reduce the initial presentation to the emergency department? And under that pillar is just more access to healthcare resources to get their acute care concerns addressed, and for the need to go to the emergency department to be reduced, but also establishing better self-management plans. So having, those discussions with rheumatology or with primary care to really establish an individualized healthcare management plan for their acute care concerns so that the patients feel confident to self-manage their concerns before needing to seek healthcare. So that was sort of under the pillar of how can we prevent initial presentations to the emergency department. And this is really the avenue where we are developing further resources in that first pillar. There's also during the emergency department visit, how can we improve that visit when they are already in the emergency department? And so what we found in our study was that the emergency department physicians were very scarcely contacting rheumatology for advice during presentations. And so, encouraging the communication between emergency department physicians and rheumatologists while in the emergency department when appropriate, And then really improving the communication between the emergency department physician and the patient while in the emergency department, because they were coming back to the emergency often because they felt that their symptoms weren't addressed, their questions weren't answered. And so if we can better explain what's going on while in the emergency department, and then the patient, feels more confident in, the explanation of why all these symptoms arose and why their presentation came about. And so really ensuring the patient has an understanding of their symptoms and diagnosis when applicable. And then the last pillar is after the emergency department visit, because we saw so many people come back, right? So how can we improve the discharge process and the care resources after discharge? So, ensuring there's appropriate access to ambulatory care follow-up, such as rheumatologists and primary care. And then improving the discharge instructions. So, what are the red flag resources that do require a return to the emergency department? And then making sure the patient understands what the time course of their symptoms are going to be. And if these symptoms persist, is that normal? Is that normal for their presentation? Should they be okay with those symptoms persisting for a certain amount of time? And when do these symptoms actually require a return to the emergency department? So again, more about really educating patients on their presentation and the sequelae of the symptoms.
So yeah, the need for patient information education, obviously, and then some sort of reform on a system level, some more achievable than others in terms of short-term and long-term, but really exciting work. So congratulations on the study. And as you said, it sounds like there's follow-up, that you guys are doing work coming out of this study. We'll be following it, and would really like to meet again and hear what the next stage is in this process. I think also for our audience to keep in mind that this is not an issue or a challenge that's isolated to Alberta, but obviously it's right across the country. So I think there are a lot of people watching and learning from you and from this study. So again, congratulations, and have a great conference in Winnipeg.
Thank you.
Thanks to our audience for joining us today. We're going to be coming back to you from Winnipeg, talking to more researchers, more clinicians about the latest in arthritis research in Canada. Thanks for joining us. See you again soon. Bye-bye.